We are jumping right into one of cardiology's most persistent and, frankly, complex clinical juggling acts.
Oh, absolutely.
We're talking about managing atrial fibrillation when it pops up in a patient who's already dealing with heart failure, specifically HFpEF heart failure with preserved ejection fraction.
It's an incredibly common overlap, but you're right, the management path it's just littered with old habits and, confusing data points.
So let's talk about the biggest mistake right out of the gate.
The biggest mistake is framing it as a binary choice. If you walk into that patient's room thinking, okay, my only job here is to decide between rate control and rhythm control,
Yeah.
you're already focusing on the wrong thing.
So if that classic rate versus rhythm debate is the wrong way to think about it, what's the real question? What's the pivot point we should be looking for?
The real question is one of pure triage. It's not about finding one single strategy that's better for everyone with AFib and HFpEF. It's about figuring out who belongs in which group. Who are the vast majority of patients that we can and should safely leave in rate control? And then who is that much smaller, highly selected minority that might actually benefit enough to justify, the risks and complexity of rhythm control?
So we're moving from a philosophical debate to something much more like personalized risk stratification.
Exactly.
I like that. It reframes the whole mission. So with that in mind, let's establish the starting line, the non-negotiable first step. When you're faced with this dual diagnosis, what is the mandated evidence-based default for every patient?
The initial move is rock solid. You must start with rate control for everyone.
Everyone.
Everyone. Control the ventricular rate first. Get the patient stable. You do not rush toward trying to restore a normal rhythm in that early phase.
Okay, let's unpack this for a minute, because I think a lot of us still wrestle with that deep-seated cardiology bias, which is, sinus rhythm is always better.
It is a strong bias, and it makes sense philosophically. Of course, the heart works best when it's regular.
Yeah.
But there are three realities that force us to start with rate control. First, it's familiar, it's safe, and the agents we use, beta blockers, calcium channel blockers, we often need those anyway to manage the underlying HFpEF symptoms. It just buys us time.
Okay, that's one. What about the second point, when we look at the big trials on antiarrhythmic drugs in this population?
Well, they told us pretty clearly that using medications to try and force the heart back into rhythm, pharmacologic rhythm control, it has consistently failed to show any real advantage over just good basic rate control.
No improvement in survival or major events.
No clear improvement. In fact, what we often saw were more side effects and sometimes even pro-arrhythmia.
So the drugs designed to fix the rhythm either don't work well enough in this context, or they introduce new risks in a heart that's already compromised.
Precisely. And the third reason is just simple risk calculus. Any procedure, especially something like catheter ablation, carries a real risk of complications. You have to make sure the patient is stable and optimized before you even think about that. So you stabilize with rate control, you address their congestion, and then you can move to the higher stakes decision-making.
That shift from stabilization to triage feels critical. So let's say we've done that. The patient is stable, their heart rate is under control. Let's say we have them under 100 beats per minute. How do we structure that decision? You mentioned a high bar, kind of triple criterion.
That's right. You need three specific things to line up perfectly before you should even start talking about escalating to rhythm control. We're not looking for just one reason. We need total alignment across symptoms, the patient's overall health, and, logistics.
Okay, let's take them one by one. The first one seems to be the most immediate, the patient's own experience.
Right. The first, and I would argue the most important question, is about their symptomatic status. We have to know. Is this patient still significantly symptomatic even though their rate is controlled and their heart failure meds are optimized?
So if we've done our job on rate control and the patient comes back and says, you know what, I feel a lot better, I'm less tired, I can walk to the mailbox again, do we just stop there?
For the vast majority, yes, you stop right there. If they're asymptomatic or their symptoms are minimal, you stick with rate control. We are not in the business of chasing a perfect ECG strip if the patient is functional and feels good.
We're treating the patient, not the monitor.
Exactly. If they feel fine, they stay put.
But what if they don't? What if their rate is controlled, but they're still telling you they're profoundly short of breath or just have zero exercise tolerance? Then we move on. What's the second query?
The second query is where we have to assess their biological resilience. We need to determine, is the patient younger and, fundamentally healthy otherwise? Do they have fewer major compounding comorbidities?
This sounds like where we have to balance the potential gain against the physiological cost of an intervention. Maybe you can give us a quick sketch of 2 different patients to illustrate this.
Absolutely. So, scenario 1, you have a 45-year-old, developed AFib after some viral illness, which led to HFpEF. They're still working, they're active, otherwise healthy. Their biological resilience is high. They've got decades of life ahead, and the quality of those decades really depends on getting this AFib sorted.
That person seems like a clear candidate to consider for rhythm control.
An excellent candidate. They stand to gain a lot of sustained benefit.
Okay, now give us the other side of that coin.
Now, consider an 82-year-old patient. They have long-standing hypertension, some COPD, mild renal issues. They're on a dozen medications. They're frail. Even if they're symptomatic, the risk of a major procedural complication or even just the side effects from antiarrhythmic drugs, it just rises exponentially.
So for that patient, the risk likely outweighs the benefit.
For that patient, rate control is almost always the kinder, safer, and ultimately more effective long-term choice. The benefits of getting them into perfect sinus rhythm just don't outweigh the very high risks of trying to get them there.
Crystal clear. So let's say we have a patient who is symptomatic and they are younger and healthier. They've cleared 2 hurdles. But you said there's a third crucial criterion. What is it?
The third is a safety and logistics check. Is the patient a low risk for the procedure itself? And this is critical. Can they get to a high-volume specialty center?
So this connects the outcome directly to the quality of the care they can access? A good result isn't guaranteed just by picking the right patient.
Precisely. The data that shows benefit from rhythm control in this selective group comes almost entirely from patients who had high-quality catheter ablations at experienced centers. We know these procedures can improve survival moderately and quality of life significantly.
When they're done well.
When they are done safely and well by specialized teams. But if that patient has other issues that raise their procedural risk, like uncontrolled sleep apnea, or just extreme frailty despite being younger, or if they live 500 miles from the nearest experienced EP lab, the whole equation just flips.
So let's summarize that threshold. Rhythm control, especially an invasive procedure, is only on the table if the patient hits the trifecta. Symptomatic, despite rate control, resilient, meaning younger and healthier, and low procedural risk, with access to expertise.
And if any one of those is a no, whether they're asymptomatic, too frail, or the procedural risk is too high, then staying with rate control is the evidence-based, sophisticated choice. You are following the data by choosing not to escalate.
That framework really clarifies the who. But let's dig into the final point of confusion. Clinicians often see data comparing rhythm control to rate control, and they kind of lump all rhythm control methods together.
This is the final trap, and we really need to hammer this home. Rhythm control that you get from a procedure is fundamentally pathophysiologically different from rhythm control you try to get with medications. The evidence on this is night and day.
So help us understand why. Why do antiarrhythmic drugs tend to fail so often in this specific context, AFib with HFpEF, when they might work just fine in a younger person with a structurally normal heart?
The core issue in HFpEF is structural remodeling. The heart isn't just failing as a pump. The chronic conditions behind it, hypertension, diabetes, obesity, they cause extensive atrial fibrosis. It's basically scarring in the atria.
And scarred tissue doesn't conduct electricity normally.
Not at all. And antiarrhythmic drugs, which work by tweaking ion channels, really struggle to be effective in that scarred, disorganized tissue.
So the medication can't get a grip on the electrical chaos, and in some cases the drug itself might even become pro-arrhythmic in that compromised environment.
Exactly. The heart failure has created a substrate that is just resistant to drug therapy. So the only way to reliably disrupt that scarred, chaotic electrical circuit is to do it mechanically, by creating precise lesions, which is what catheter ablation does.
And that's fascinating because it means the survival benefits and the quality of life improvements we see are tied specifically to the success of those catheter-based procedures.
That's it. The benefit is procedural. It's mechanical. It is not pharmacologic. Medications alone for rhythm control have shown no clear superior advantage over rate control in this population.
And that nuance really informs the entire decision tree we just built. If you're deciding on rhythm control, you are really deciding on a procedure. If the patient isn't a good candidate for the procedure, they aren't a good candidate for rhythm control, period.
That is the definitive clinical rule.
So it all comes together. Start conservatively, assess function, assess resilience, and then assess access to a high-quality procedure. If all 3 line up, you escalate. If not, you stay put where the patient is safest.
And by sticking to that systematic, evidence-based pathway, you are giving the patient management that is truly tailored to their risk profile. It gives you the confidence to manage conservatively when that is, in fact, the best possible intervention.
Right. Staying in rate control when it's appropriate isn't a failure of therapy.
It's an informed, expert choice. It transforms the debate from that old abstract argument into a personalized clinical triage, which is just better medicine.
It is.
And that kind of brings us to the bigger picture looking forward. Technology is always evolving. We're seeing huge advancements in ablation, but also in less invasive and non-pharmacological methods, things like pulse field ablation or even different pacing strategies for rate control.
Which raises a really important question for the future.
It does. It raises a question for all of us to think about. How might these emerging, less invasive procedures start to shift the strict age and health criteria we just discussed? Will we soon be able to safely offer rhythm control to a slightly older or maybe a slightly frailer group of patients with AFib and HFpEF? That's something every clinician really needs to keep in the back of their mind as the evidence evolves over the next few years.
A perfect challenge to mull over as we wrap up this deep dive into personalized cardiac decision-making.